So starting with, the epic of Mahabharata. During the war at Kurukshetra, it was actually, Krishna asked Yudhishthir, who was the embodiment of, all the good things and wisdom, to announce that Ashwathama is dead. It was half truth. He was not dead per se, but what it resulted in is, it resulted in winning the war at that point of time, which was likely of good over evil. Now, what does it actually tells us? It actually tells us that sometimes these moments teach us something which is very critical. Something that, it's not that you have to do everything and comply to everything to make sure that you always have a good outcome, right? In one of the WHO 2022 clinical reports, it just came out that 56% of the professional healthcare professions, they spoke about and said that too much focus on compliance reduces their work output. In one of the other studies also, it was looked at that, 60% of the people felt that more of clinical documentation actually detracts them from, putting in an effort towards patient care on the ground. So that's what the data talks to us, and that's what the data is, or the reality is all about. Now, if I have to ask all of you sitting in the audience two questions. One, how many of you would, if you have to choose between what you are actually doing as per what the policy says and what is right for the patient, how many of you feel that there is a difference? That, the policy says something, but what is actually right for the patient is something else. Can you just raise your hands? Cool. And now I really want all of you to be a little honest. How many of you have actually uploaded a policy just for the heck of a survey? I know that yesterday there was a debate about it, but you have just uploaded a policy or prepared a policy that it's not going to help you. It's not gonna be implemented well in your organization, but you have uploaded it for the heck of it. How many of you feel that ways? Okay, I see a less participation in it. Looks like most of you are very confident about it. But with that, I just want to say that these are just not the questions, right? These are kind of signals that largely tells us that, good patient outcome is not about breaking rules, breaking the policies or not following the policies, but bending them for the right reasons when they are required, largely to be done in the service of safety, compassion, and good outcomes, whether clinical or non-clinical. So that's largely about a quick intro about the topic. This is not a debate session. This is more of a discussion session. And I would request my co-moderator to talk to all of us about her inputs.
Thanks, Gaurav. Very good afternoon, everyone. And I think Gaurav has set the context, right for this discussion. So these couple of questions that Gaurav just asked, I'm sure all of you relate to. I've been a quality manager for most of my career, and these are questions that keep popping into our minds as well. And along with that, I'd like to also ask how many of us have actually put a policy in place because we wanted to close a non-compliance which has come up in our NABH report. So many times we may feel it needs to be closed because the standard says so. How do we convince stakeholders, and who are these stakeholders? Yes, at the forefront we have our patients, but they are not the only stakeholders. We have a lot of other people we have to deal with. People who work at the ground level, people who are in the boardroom. It's very important that the solutions, or rather the statements we make, are aligned to everybody who are involved. Now, saying something which is a standard is one thing, and putting it into practicality is another thing. Second thing is, at the end of the day, why are we doing this? Unless we are all convinced why we are doing this, we may not be able to sustain this. So quality in general are not just about meeting some standards for the sake of an external accrediting body. It's also about enabling people and ensuring these solutions have, there is an effectiveness seen at the ground level from the operations perspective, as well as enabling patient-centered care. So a lot of questions and a lot of trials that we have undergone, I'm sure at all your level, our level, will be addressed today. And these are some of the industry experts who have had years of experience working in quality as well as in administrative levels. And these are going to be some real scenarios, and I'm sure it's going to be interesting for all of you. And let's hear it from the experts. Over to you, Gaurav.
Thanks, Anna, again. So today we have the leaders with us who are just not, who have faced the heats of the corridors, but also looked at the policies and how to improve different policies and systems on the ground. And we are going to pose some interesting questions to them to understand from them how did they handle situations when the compliance met actually chaos. So we have 3 rounds largely for this session. The first round is when compliance hits reality. So my first question for that is to Dr. Sheikh Mohiuddin. A system-wide compliance dashboard shows declining scores in multiple departments. Leadership wants immediate corrective actions. As such, any leader look at it, I want it now. Even that may take some time to get it improved, but obviously they want it now. And when they ask for it, departments say that I have got my operational constraints and I really can't work much on that. How would you respond as a chief quality officer for your institution? Central push or a unit level flexibility?
Yeah, thank you. Hope you are able to hear me. Yes. Thank you, Gaurav, for that question. I think the topic and the question, they both gel together, walking the tightrope. And that's what exactly happens when what to do. Is it the central push, or is it a kind of a hospital level kind of empowerment? But I would balance, and I would stand in the middle saying, yes, both are required, but there should be some sort of approach to it. And I think the best approach is, I call it as an ABCDE approach. And what I mean by that is, A is alignment. So that's a very important thing to begin with. There should be a very clear alignment on non-compensatory issues. We cannot compromise on certain things. And that comes from the governance, that comes from the leadership, that comes from the central push. And that has to be there, because if that is not strong, then the organizations or the hospitals, they will not have a very clear sight on where to progress. So that central push needs to be there on at a group level. And then what happens is, how you deliver that needs to be kind of decentralized, and let the front-enders speak and put the plans that can actually work for them. And I think the question mentions a lot of departments, so one size cannot fit all. Again, it has to be tailored to that particular department. So that's about A, alignment. B, I think as the group, you need to create a very good blueprint of success for those people on the ground, because you are the leadership for those hospitals. So that the blueprint should be co-designed with the ownership of hospitals. When I say C is your corporate leadership has to have a very clear communication plan on what you're going to do. And again, you cannot run and do all at once. So kind of a tiered approach on level 1, 2, 3. These are the ones which need complete ownership and complete support from the centralized approach, whereas maybe tier 2, they can do a partial approach where one of the person can represent onto that hospital leadership and govern them, and maybe tier 1 or those who can self-manage, and we can push them, just provide the support necessary from the top. So that's about C. And D and E can be clubbed together. One is the data information should be available, and the data should be available for the board. And when I say E is about education. So there could be a lot of peer learning, groups to groups, departments to departments. One that is growing well, improving well, can learn from the others. So I think that's, in summarizing, ABCD approach would suit for this kind of
Thank you
thing.
so much.
Thank you.
Though you took a little extra time, but very gently he's introduced one more acronym that can get into what could be called as a policy for the future. So thank you for that. And I would request the other panelists to please restrict to 3 minutes. My next question goes to Dr. Jennifer. You are notified of a near miss serious medication error in your particular hospital. Obviously, you do have all the policies in place, but then the awareness among the frontline staff is a little poor on that. How do you balance a rapid risk response with sustainable learning across the hospital, which is largely a challenge for most of the healthcare institutions?
Thank you for this important question. Basically, this is something that we face every day. How do we go around near misses, and how do we do those investigations, and how do we have the frontliners be involved and engage in reporting the near miss? The first thing that we have to look into whenever patient safety event happens is we need to make sure that the patient is not harmed. That is the first thing that we need to look into. Now, this is a near miss. It means that it did not reach the patient, so the patient is not harmed, but that does not mean that we just have to sit and do nothing about it. This time, nothing happened, but next time, something would happen to the patient. And talking about a high alert medication, we're talking about basically a sentinel event could occur because of that. So the first thing we have to do, a rapid response, risk response, which is do a prompt investigation to see what actually happened on the ground, involve the stakeholders, the nursing, the physicians, the pharmacy, to identify what happened. Was it an ordering? Was it a prescribing error? Was it a dispensing? Was it administration error, monitoring error, or even was it a storage error? So that is the rapid response investigation within 24 hours to identify what happens and engaging the stakeholders to make sure that everybody is involved and engaged. Then we have to make sure that this result is being discussed and communicated in safety huddles, in the morning huddles of the nursing team, pharmacy, and the leadership rounds as well. This is for us the rapid response risk team, let's say. The next thing is you want to prevent this from happening, and you want people to be more engaged. So we need to do a root cause analysis, because we all know that when a gap happens, it's not only one issue that led to the safety event, it's multiple gaps happening in our different safety layers that happen at the same time that led to the event. So we do an in-depth analysis. We do use the 5 whys. We identify what are our system failures, human failures, equipment, environment, policies, processes. So we kind of identify those gaps. We come up with recommendations and action plans. We identify the stakeholders that need to be involved in those action plans and recommendations, and we put a timeline for implementation. And usually what we need to do is our risk department or quality department needs to make sure that these are being followed up, and we need to engage the stakeholders in these recommendations. Learning, education has to be part of it, so we need to do modules of education related to our gaps identified, and it shouldn't be just one-time thing. It has to be continuous learning, and it has to be mandatory for all our staff as well. That is for me. This is our response. I'm trying to be on time. One more thing I want to add, adding to Dr. Shaik, is leadership support and the culture is the most important thing. We can do all of those, but however, if you don't have a leadership that's orchestrating, that's managing, that ensuring that the culture of safety is there, and it's important to have that, we're not going to be able to implement any changes. So thank you.
So thank you. I think very well articulated the next steps on what happens if there is an incident. Please stick to timelines once again. My next question is to Ms. Gracy. You are kind of rolling out a digital handover system in your hospital. Technology is great. You have done all the training. Obviously, compliance is poor. So what strategy would you adopt to increase the uptake without compromising either the timelines that you have been given or making sure that you don't lose out on clinician trust?
Thank you, Gaurav, for that question. Now, what is happening in my own hospital with the same experience I am going to tell you. See, first we may have to engage our clinicians at the early stage. And then we also should have a task force for the digital intervention, and that task force should approach to our clinicians, maybe on a departmental basis or an individual basis, and then you see that where they are lacking, and that particular base you may have to talk to them. That's the second thing. But and you realign your training based on the requirement of the doctor. See what has happened now today. The EMR and the IT is so difficult that when you have to go to a patient data, you have to click 5 times or 10 times. So that's one of the major problem what they are facing. See that will be seamlessly adopted by everyone, so that they will use that. Now again, you can build an accountability between the people. When I say accountability, I don't want to tell you that you punish the people. It should not be punitive, but at the same time, maybe we can have a small incentive. At the same time, we can have a pilot study at one, maybe basically to the high risk areas, ICU and all, and that success you can bring, and that you can put it into other areas, so that may work. And you also can take the help of some early users. So there will be some people who will be already accustomed to that. So you can call them and let them be your spokesperson for that. This is what again I see. Another thing, you make your data visible. See what you are doing, people are not knowing. So let it visible to them. Let them understand, yes, they have introduced and this happened to their department. So I'll also do that. So this will be benefit of that. Let them understand. Otherwise, they don't know the benefit. They think more work is being given, double documentation. So those is the feeling of those people. I think if you can do that, that will be better in our hospital. But we do that, and that I think that we can do everywhere. Thank you.
So thank you. I think you did touch on some of the pain points that all of us face. I also face similar pain points. We have been trying and working hard towards making hospital digital. Though all of us claim that we are very digital savvy, we do everything digital, but then when it comes to implementation, it's a challenge. So thank you for sharing that information.
We move on to our next panelist, Ms. Rashmi Srivastava. That side, yes. So during a routine group level quality review, a high performing hospital reports lower scores due to a patient centric workload that bypasses a mandated protocol. How do you handle innovation versus policy uniformity across units?
Thank you, Anna, for asking this. I think you are aware that Narayana Health as a group, we are a JCI Enterprise accredited organization, and consistency and standardization is a key for us, right? And that has to be maintained across the group. So your question is right. I mean, this is our regular scenario which we face, that units are taking or the hospitals are taking work around, but that is something is a marker that something is happening at the unit, because innovation is happening, and we have to encourage or open that loop that the local innovation comes to us and which can be incorporated in our policy. But as we know that the balancing between the consistency, protocol, standardization versus the local innovation has to be balanced for any good system. If you want to make a good system, you have to balance both, right? So for that, we have a very structured process, which we call it in our group is either approved variation or we call it structured flexibility, right? So any unit or any hospital or any department which wants to do an innovation or they want to do a workaround with the policy which is standardized at the group level, they send us the requirement that this is a requirement, and why we have done is what is the trigger, what is going to change, what is the impact of that, and that gets reviewed at the corporate level or maybe hospital leadership level, and post that we decide whether it has to be incorporated or it has to be moved into a shared learning model which can be incorporated across the group. So I mean, we don't give them a low score. We always value that value based behavior, because local innovation will not come if the unit is not, or the hospital is not aware that what is happening on the ground, and they are not aware of the policies and procedures. So they look at the policy procedure, they look at the ground practice, they come with the local innovation, and which is one of the best marker for the continuous improvement. So we always encourage that, and we get that flexibility and try to incorporate in our system. And that is giving us a culture of continuous improvement in entire Narayana Health. Thank you.
Thanks,
So
Rashmi.
I'm on time.
That's a great balancing act, what quality managers do often, right? And there needs to be a balancing act at the leadership level too, and probably certain non-negotiables which need to be looked into. Moving on to our next panelist, Dr. Sravan Kumar. This is something that's quite a familiar thing, in most of our units. JCI reaccreditation is due. Staff fatigue is high. A few critical safety drills haven't been done. Do you prioritize documentation readiness or ground level drill execution with limited time left?
Thank you for the question, Dr. Anna. So for me, it's a no-brainer. We would have to do the drills because your accreditation would be at stake. But the whole point of doing the accreditation, we need to understand, is for patient safety. So at the same time, you need to alleviate the fatigue and stress among employees. So as a quality professional, I would do 4 things to address this. One is communication, clear communication on why do we do what we're doing. Driving the narrative using patient safety as the component versus accreditation. The second thing would be risk assessment to prioritize which areas are at patient safety risks when it comes to not doing these drills. For example, a fire drill in a utility systems area versus in an outpatient department, a chemical spill in a laboratory versus again in patient care areas. The third thing is integrating the drills into the daily workflow and making it fun. The standards, no matter what standards you take, they're not prescriptive. How should you do these drills? So often it's the quality professionals who interpret these things in different ways. So there are multiple ways you can do the drills, doing unit-based drills or tabletop exercises or just simulation exercises without having to involve everyone disrupting the function of the entire hospital. The fourth thing would be providing some support in terms of documentation. Maybe a member of the quality team or administration could go up to the unit and help them in documenting the drills and making sure that the staff don't feel the burden that it is their responsibility to do the drills and also document. So these are the 4 things I would do. Thank you.
Thank you, Dr. Sravan. So to add to that, I think drills should be a part of everyday activity with a proper strategy and not something done just before. So we don't face that situation of fatigue and you're ever ready for any external assessment. Moving on to our next panelist, Dr. Deepinder Singh. One of your regional hospitals has had a recurring patient complaint related to, and I'm sure we all experience this, related to waiting time and discharge time. How do you approach system-level practical changes without breaking compliance rules?
Sure. Thank you for the question. In fact, this is a problem for most of the hospital when we talk about the waiting time, and of course, discharge is one of the commonest thing, including the OPD also is the next one. So what we do in our scenario and practicality is that understand exactly what are the requirements. Now, what we do is that we generally get everything right except for engagement of patients. We somehow fail to ask the way it should be, that how much is your expected waiting time. When that is not asked, probably we are ending up in a wrong footing. So that's the first thing. And when we are talking about expectation, setting expectation, this should be set at every point. Like every interaction with the staff and the patient should be setting an expectation, which is often missing out at the time of discharge, how much you will have to wait at the time of billing, waiting for the doctor, consultation. So I think every point, if all of us have been patients at any point of time, if we know exactly how much is the time approximate, we don't mind. Okay, if I'm going for a movie ticket and it's a new movie release, and imagine there's no online booking, I will have to stand in a queue, and I don't mind like 1 hour, 2 hour also. But if I'm just out of people are coming to the hospital, they're not happy people. Okay, they are somebody is not well, I am not well, my father is not well, mother is not well, so they're not happy people. So to set them expectation, they're already frustrated, is very, very important. So that's important channel to set the expectation. And also we need to have a monitoring mechanism in which they can engage. So you have seen discharge boards in the patient rooms. So that plays a huge role. A digital board we have recently replaced. So a digital board which patient can interact, patient can know what is the time for me to discharge out of the hospital, who is coming to care for me throughout the day. That's important. And there is no best way to do the things. That's one of the things which I personally learned. We need to start towards an improvement. We cannot wait, okay, this is the time when we will be launching this to have this kind of outcome, every improvement, a small improvement is an improvement. So we need to appreciate staff. I think staff appreciation is also missing in most of the hospital, including where I work sometimes. So appreciation at every point of time, even a small improvement in the waiting time should be appreciated, should be celebrated, and then move on to the next target. So engagement with the leadership, engagement with the patients, and also with the staff is important role, which helps us to make sure that we are on the same page. Thank you.
Thank you, Dr. Singh. We move on to our next panelist, Dr. Neesha Nair. So, hi. So you're designing a group-wide audit checklist. Some hospitals in the network are highly digitized. Others still use paper-based system. Again, something we can relate to when you're working as, at a group level. So how do you build a framework that's both scalable and fair across units?
Thank you, Dr. Anna, for this question. So when we are handling group, it's a big diverse network. So it's very important that we include ingredients of flexibility. It's very important that we are inclusive and we are consistent. Okay, define a universal standard of your checklist. First thing you can do is start with a survey. But then again, that can be cold. So it's very important that you include some interviews and discuss with your team members across the group that, what's the current status. Once you have the information in place, this would have also helped you contact, understand the challenges and all. Next, move to defining a universal audit criteria. What is it that you would like to look into so that you can include it in the checklist? Try to develop a modular checklist, so you can have some universal parameters in it, and then you can have sections where units can customize it. Now, when you have a group which is digitalized and few of your hospitals are paper-based, again, it becomes very important that you have structured formats when it comes to your paper-based checklist, which matches to your digital components also. Now, there are multiple tools that are available. One of them, you need to leverage technology. And during this time, you also need to understand that when you're designing this, how are you going to, have a transition from paper-based to a digital model of your units? This is your opportunity for change management. So again, here, you can use multiple tools like Microsoft Forms. You have Jot Forms, which are subscription-based. If you have total paper-based audit tools, which are standardized, maybe you can convert them into an Excel and upload it on your QMS systems. Like, for example, we have MedBlaze, which can, give you standardized dashboards once this data is uploaded. We have newer technologies like OCR, these can also be looked into. But again, the challenge would be the cost, the server storage and all that. And also, if you are aiming to go green, it may, not serve the purpose, or it may be somewhere like, again, you're storing papers. So think in a way that, you can incorporate it well. Google Sheets are also available, which are the easiest to use. But again, some countries may have limitations because where the data is getting stored, that's one important thing to be looked into. So accordingly, you choose a module or a platform that can be utilized, and that's how you move forward. Very important to do pilots, very important to do data validation. And the last important thing I would like to mention is that because of the challenges of not being fully digitalized, not let your units feel that they are being penalized. It should be a uniform standard method to, making everyone inclusive and introduced.
Thank you, Dr. Neesha. We move on to round 2, and Gaurav, over to you.
Thanks. So you've heard all their insights. Now it's time to pitch. The next session that we have is called the Shock Tank or the Shark Tank moment. So this particular moment is about asking them a particular situation in which they are going to pitch their solution, what's on their mind in 60 seconds. And you need to tell them if you're going to implement that solution in your hospital. Now, this session is not about, asking you for any funding. We're not going to ask you for any money. But they're going to fight for the impact that they're going to create with their ideas. So I'll move to, and please, you need to restrict to 60 seconds, which is exactly a minute and not more than that. So please make sure you have put in your points. And after each one of them finish their pitch, I would request the audience to kind of either by showing your hands if you agree with their pitch, or clap for them to make them understand, whether it is this or whether it is this. Okay, so we start with Shaik, back you again. Your challenge is, how would you embed quality ownership across all levels without losing out on standardization?
So I will start with a simple idea that we sometime back implemented. So we create a box, okay? The box is basically your idea box. And since we have got many hospitals, we make this box travel across the hospital to collect ideas from the people at the forefront. Once those ideas are collected, you have a standardized approach. So you're not losing standardization, but at the same time, you are giving enough opportunity for everyone at the bedside to participate in that. So once you collect those ideas, they all get collated, they all get formalized into some sort of group to get that standardization. And then we work on those key pain points of the organization, so that we work in uniformity, we work with standardized approach, yet we maintain to resolve the problems at the bedside very quickly with the ground team. Hope I get some thumbs up on
great,
this.
60-second solution. How many of you would agree and would want to implement this idea in your hospital? Raise your hands, clap, please show him support. Great, thank you. Moving to Dr. Jennifer. What's one bold step to normalize open risk reporting in hospitals? One bold step, 60 seconds.
So let me start with a story. So once upon a time, and once upon a shift in a hospital not so far away, a nurse caught a near miss, a medication that was not labeled right. She paused, she thought, am I going to be reporting this or not? What did she do, you think? She ignored and she moved on. So the problem, the villain here is not the nurse, it's a system that does not encourage us to report errors. And how do we have to move around it and have a bold step to change this? By creating a culture that's reporting, a culture that celebrates reporting. So moving from punishment of reporting to encouraging people to report. How do we do that? I create a program that's called Catch One and Report One. So catch one, share one, report one. This is a strategy to be used every week. There is every unit, every department will have to report at least, catch and report at least one near miss or one risk to be shared as a team. So what do we do with this? This win is usually spotlighted in newsletter, in leadership rounds, and of course in safety huddles. So here we are actually valuing risk reporting, we are encouraging, we are recognizing, and we are changing the culture of risk reporting from fear to a culture of, reporting with pride, okay? So this is
Jennifer, you're out of time. Thank you so much. How many of you would pitch in for this idea? Hands, clap. Thank you.
Thank you.
Moving on to Ms. Gracy. You're facing EMR fatigue. How do you make quality tech a friend, not a foe?
See, the EMR fatigue is being considered as the cognitive and physical exertion of a particular person due to excessive use of EMR. First, we have to identify what can be the causes of that. Specifically, that your design is not proper, poorly managed, and then repeated documentation. So you have to see that it will be a collaborative one. That's what I just would like to say. And the users have to be taken into confidence and take the benefit or take the knowledge from the users and let them say that which is much beneficial to them, so that that fatigue can be avoided. That is my foremost thing what I think about.
Thank you. Thank you. Clap or hands for her. Great. Please map the time. Rashmi, when accreditation feels overwhelming, how do you keep teams aligned with patient-first thinking?
Okay. So, Gaurav, shall I call you Shark or Shock?
It's up to you.
Okay.
Your 20 seconds gone.
Oh, no. So, I want to pitch for the debate what happened yesterday is about wo 5 din, right? So I don't want that wo panch din scenario in any of the hospital. Okay, so we have developed a system which is an over and above, which embeds all your accreditation standard to as a tool to all your policies and processes, and the process owners can continue to do their daily work. Okay, so we are always in the 60 to 70% readiness status. So that's the impact. And the second one is another 20%. So we introduce an accreditation tracker or an AI-based tracker, which can be used to, monitor all the steps, what is required to ensure that you are in the readiness stage. So by, end of your 3 months or before 3 months, you are ready for the accreditation.
Rashmi, time over. Can I please request the team to map 60 seconds only? You will get less responses here. Sorry for that. Hands or clap for her. Though half, but solution accepted by many of them. Sravan, next question to you. In a multicultural, high turnover environment, how do you build a resilient patient safety culture? 60 seconds.
Daily or weekly safety huddles in each and every unit, and sharing stories of the incidents that have happened, and then talking about corrective actions done without naming or taking any names. I think that would go a long way in improving or setting up a culture of patient safety.
Great. Hands or clap for her. For him, sorry. I'm sorry, I apologize. Dr. Deepinder, compliance fatigue is real. How do you simplify audits and documentation without compromising on quality?
Great. A practical example. So first of all, we need to audit whatever is important. We should not audit because there is a checklist or somebody has told us. So value is more important than volume. That's the first thing. What we had tried out is that we were finding a challenge that doctors' medical documentation is like not being properly done. Like documentation is not great. So we asked every doctor of a hospital to do one audit of another doctor, okay, name concealed, once in a month. That's it. So once in a month, we got like 300 doctors in that particular hospital. We got 300 records. Not only that improved that what is important for me, but that also meant that 300 records are added to a quantification every year. So every person, and same thing we replicated to the different departments, that every person does one audit on a particular topic, which made a big feel in that, and everybody not only learned, but also imbibed on the practice. Thank you.
Thank you. For him, your response. Good. And the last question to Dr. Neesha. How do you maintain high reliability in healthcare when budgets and resources are constantly stretched?
So very important that we look into reliable processes in the hospital for patient safety and care. One of the solutions which I would like to put forward is a simple bedside early warning scoring system, which is a low-tech, high-impact tool which empowers frontline staff to detect the early warning signs of patient decline, using just a small template. So we have used this in our low resource settings. Implementing this tool, it can help you reduce unplanned admissions, ICU admissions, which the statistic shows that around 25% of reduction has been there, and errors can go down by 15%. So through this, you can maintain high reliable care and also ensure patient safety.
Thank you. Love or support for her pitch. Great. So over to you, Anna.
Thanks, Gaurav. So this is towards the end of our session, but we want to do a crystal ball moment, because we've heard a lot, right? But we're looking into the future. This is exactly what has been happening around. We have experienced many of the situations, and we heard some wonderful thoughts and solutions from our panelists. So this is going to be a 10-second crystal ball moment where you have to prophesy where do you see the future of healthcare quality in 2030. So it's going to be quick, and we start from Dr. Jennifer. And
okay, I would see it in risk awareness culture. I think this is something that we're lacking, and we need to have more risk awareness in our everyday activities in the hospital.
Thank you. Rashmi.
From quality department to become a compliance gatekeeper to strategic care enablers, or maybe from policing to a purposeful partnership with the process owners.
Lovely. Next.
Moving away of the accreditation bodies, the state healthcare authorities will become accreditation bodies themselves, setting up standards and monitoring compliance with the hospitals.
Thank you. Dr. Deepinder.
Everything will be monitored. Everything means every activity of a patient or voice I'm speaking or something will be monitored, recorded, actions will be triggered, responses will be requested, and actions will be like implemented. So healthcare, I perceive, is getting more safer, Be it AI or be it technology, health is definitely going to be a safer, I hope, in 2030.
Thank you. Dr. Neesha?
So accreditation bodies will need to revise their standards to include quality and patient safety indicators related to healthcare services provided by robo-doctors. Okay, these robo-doctors will not only offer treatment plans, but also create personalized TikTok dance challenges for rehabilitation exercises. And as physical doctors become increasingly rare, we will conduct clinical indicator review meetings using holographic doctors. This approach will ensure 100% committee compliance, elevating the burden on hospitals to prepare meetings just before the survey.
Thank you. Slightly over 10 seconds. Over to you, Dr. Shaik.
So one is my prediction and one is my wish. And the wish is I want all the quality professionals to become data scientists. And one prediction is that we will be more of a predictive in nature. So to go there, that's the reason I said we should be data scientists as we move along. Thank you.
Thanks. Ma'am, Gracie madam.
That's phone drop.
I just would like to say the entire country, the whole hospital must go for accreditation.
Go for?
Accreditation.
Accreditation.
Yeah. And then one another thing, we may have to redesign our thing to match the latest or the current need of the healthcare requirement.
Lovely. I thought, it would be somebody would say the CQO would be above the CEO.
You never know.
But lovely session and thanks, Dr. Parag. So thank you all. We had a great session. I'm sure that you also had some great insights. A big thank you to all the panelists for spending their time.